It's about time to begin the afternoon session. The next speaker is Dr. Kathryn Meurs from North Carolina State. And she will be introduced by Dr. Mike Criscitiello, who is Associate Dean for Research and Graduate Studies in the College of Veterinary Medicine here at Texas A&M. So, Mike, it's all yours.
Thank you, Lauren, and thank you for putting together this terrific day. I'm gonna take the prerogative here at the lectern to also share my quick little Jim story. So I moved here in 2008, and I didn't have the genetics chops to have an intellectual scientific conversation with Jim like the rest of you can, but I could hang with him talking about college basketball. And so I could keep up with the love and the lore. And we both liked the underdog, as long as they weren't playing our blue blood team that we were pulling for. And we both shared an appreciation for coaches that primarily thought of themselves as teachers, and basketball coaches second. And, I think he bemoaned the one that you guys just fired a couple weeks ago. But, he loved to see the little shorter three-point guy reining them in, or as naturally I appreciated it when a slightly larger DJ Burns kind of character was clearing the paint and getting on the boards. Jim and I were always, every year, diametrically opposed in our opinion of the merits of the team in Durham, North Carolina, and we just were never on the same page about that. But I was always so thrilled that the scientific giant in my department would text me every now and then, and ask me, what I thought about the Aggies point guard, or whether I was just watching the game. Did you see that? And it would always crest annually this time of year. This weekend actually would be the peak of those texts and that banter back and forth that sometime I got to enjoy with Jim Womack. Reflexively, this past Sunday at 6:35 p.m., I looked at my phone because I expected, and those of you that know Dr. Womack knew that at heart, he was a math teacher, and I expected to see a text very, very politely, like Jim would do, but also very quantitatively destroying the logic of North Carolina getting in the tournament. But he probably would have also thrown in why Ashley Seabury's West Virginia Mountaineers should have been in the field for the big dance, but I didn't get it this year, and I hate that. I don't think Jim would mind if he looked out and saw us looking at the live stream under the table today or tonight, or even slipping down the hall to the bar to watch an overtime game finish. I think that might make him smile. But you don't have to do that for the next hour, because the Houston game's not even going to be at halftime, and we're in for a real treat. What I'm primarily up here for is to introduce Kathryn Meurs. She's a veterinary cardiologist and academic leader who currently serves as the Randall B. Terry Dean of the College of Veterinary Medicine at North Carolina State University. She earned her DVM degree from the University of Wisconsin-Madison, who is up 29-22 over Montana, so you don't have to worry about that game either. She completed a small animal internship at NC State, followed by a cardiology residency right here at Texas A&M University. She is board certified by the American College of Veterinary Internal Medicine and holds a PhD in genetics from Texas A&M she got with Jim Womack. Prior to joining NC State, Dr. Meurs held faculty and administrative positions at Washington State University's College of Veterinary Medicine and Ohio State's University's College of Veterinary Medicine. In 2011, she returned to NC State as Associate Dean for Research and Graduate Studies. Under her leadership, the college's annual extramural and federal research funding, enviably from my position, experienced significant growth. She also developed the college's first undergraduate research program and a combined DVM Master of Public Health program that I want to call out because it was with the University of North Carolina at Chapel Hill's Gillings School of Public Health. It was brilliant, terrific partnership of the two good schools in North Carolina's Research Triangle. In April of 2022, Dr. Meurs was appointed Dean of the North Carolina State College of Veterinary Medicine, becoming the first female Dean of the college and the inaugural recipient of the Randall B. Terry Jr. College of Veterinary Medicine Endowed Dean's Chair. Dr. Meurs' research focuses on the genetic basis of cardiovascular disease, particularly cardiomyopathies in companion animals. Her work has significantly advanced understanding of familial aspects of these diseases, leading to improved diagnostics and treatments. Her leadership continues to shape the future of veterinary medicine, fostering a culture of innovation and excellence in research, education, and clinical practice. Dr. Meurs has served as chair of the American Veterinary Medical Association Council of Research, chair of the American Association of Veterinary Medical Colleges Research Committee, and chair of the Morris Animal Foundation Scientific Board, among others. Kate leads from the front. Her dedication to advancing veterinary medicine and her commitment to education have made her a respected leader in the field. We're so very, very glad that she is here with us today. Let's give her a big round of applause.
Such a kind introduction. Thank you so much. Thank you all. It is such an incredible honor to be back here today, and it just actually fills me with a little bit of sadness that Jim isn't here, a lot of sadness, and but it's so wonderful to be in this room and see so many familiar faces. I feel as if it hasn't been decades, but it has been, but I'm so honored to be back. And David started us this morning saying he was one of Jim's pity cases, and I have to say that I was as well. So as Mike said, I really came here to be a cardiologist. I was a veterinarian, and I, for whatever reasons, decided I wanted to be a veterinary cardiologist, and I was doing my residency in the hospital with a great mentor, Matt Miller. But I was seeing a lot of purebred animals with heart disease, and Doberman Pinscher and boxer dogs and cats that were specific breeds. And we didn't really know what caused those diseases. We would often say, well, it might be inherited, but we don't really know. And so I was talking to Matt that I really wanted to study genetics because I had this belief, which I now know is very wrong, that maybe if you could find the genetic mutation, you could breed it out and you could get rid of these horrible diseases, because often heart disease in animals, small animals, dogs and cats, they die from it. We don't do transplants. The treatments aren't very good. So I wanted to put an end, and I thought, well, you find a genetic mutation, that'll be the end of it. So, which is clearly very wrong. So I was talking to Matt, and Matt's wife said, oh, I know this Dr. Womack, and before I knew it, she'd set up a meeting and took me along and went over to see Jim, and he'd never met me. I don't even know if he knew Matt's wife, who was a surgeon in the small animal hospital, and he met with us, and Terry said, Kate here is one of our residents, she's interested in genetics, will you take her on as a PhD student? And he said yes, and I thought, and then she said, and she wants to work on cat and dog heart disease. And he never backed down. I mean, I just can't imagine all of the work he's done. He had an amazing lab at that time. This was mid-1990s. He always had an amazing lab, but full of people doing cattle genomics. And here these two women had showed up, and he just agreed to take on somebody to study cat genetics. So he took me into the lab, and John August would provide some money for me, a little bit of money occasionally, which was amazing to have supply money, because Jim couldn't very well justify his USDA or NIH money to be looking at cat heart disease. But it was amazing. And that lab, as many of you have talked about today, it was just this incredible milieu of excited people that loved what they were doing. And Jim had a magic of kind of just standing back and waiting to see what happened with these people. And we'd meet weekly, and sometimes there'd be food. And it was amazing. And it's been a heck of a ride. Lauren was on my graduate committee. I'm so thankful to A&M. And so it's an honor to be here. And I'll have hopefully many more opportunities to talk about Jim. But today, I wanted to talk about what I believe is the power of clinical genetics. So a brief roadmap, and I promise not to go on long here in my session, but I wanted to begin with talking about how most clinicians think about medicine as reactive, and how I think veterinarians and even MDs really imagined that genetics was going to change that and we could move it to become more proactive. And we made some assumptions, some of which I believe are wrong, but there is a real future to the power of clinical genetics for animals and for humans, as we're already seeing. So if I begin thinking about the history of medicine, whether that's for humans or for animals, if you're a veterinarian or a human physician, we really tend to train people thinking about reacting. We teach them to diagnose based on what they see in that animal that's in front of them. And often that's based on what are the symptoms? Is that patient coughing, vomiting? What are those symptoms? And then you react, you make a diagnosis. That disease is already present and you're reacting to it being there and what you find through the blood work or exam or the history. And that started 100 years ago or more, hundreds of years ago. That's how medicine was started. Somebody gets sick, somebody else reacts to that, tries to help. Today, still very much that way. Much of what we do is looking at diagnostic tests and reacting to them, making a diagnosis based on those abnormalities we see. And treatment is much the same. It's often based on actually how do we provide medications that will control the symptoms, often not so much based on can I cure this disease, because we may not really know exactly how that disease is caused. But again, it's reacting to what are the symptoms this patient has, how can I make them feel better? If we look back to when there was a little bit of a revolution of that, and that was maybe in the 1950s, that's when scientists really began to have a breakthrough around infectious disease. Antibiotics got better, there were vaccines. They also had some breakthroughs with nutrition, and so we were actually starting to live a little bit longer. And if you look at this chart of infant mortality per 1,000 births, you see there was really a big drop-off as you hit sort of the 1950s, that babies were surviving, people were beginning to live through these infectious diseases because we were getting better at actually preventing. So here with infectious diseases, we are proactive. We've discovered you can give a vaccine, you can do something before the patient gets sick to prevent that. Now, as that happened, those infectious diseases started to die down a little bit. We didn't see as many of them. And we also started dealing with nutrition. We realized that animals and humans needed certain diets, and that kept them healthier. And so as some of those diseases dropped, we started to recognize other causes of disease, and genetics was one of those. And that is really, I think, in my mind, where you start to see some of the breakthroughs and some of the medical clinicians and medical scientists thinking about how are these genetic diseases, is it truly inherited? How are they passed on? And can we find a cause of it? Now, that timeline, I think, corresponds a little bit to also some socioeconomic changes. After World War II, there was automation. Things got a little bit easier. Humans maybe had a little bit more spare time. Economically, the world was a little bit better too, so there was a little bit more money. And people started focusing on, as a hobby, breeding animals, often because of the way they looked. I will confess, I have owned all of these animals up here. They are adorable, they are wonderful. And they are largely selected because of the way they looked. Now, I will say, I didn't go out to get them because of the way they looked. I ended up with them because they had health problems, because often being born with no hair, if you're a cat, is not necessarily the best thing, or being a dog with so many wrinkles is not always the best thing. But so the point is, as the world changed and animal breeding became a hobby, we started focusing on breeding animals for a look, not very much for what made them healthier. And we didn't even know how to do that. It didn't occur to us early on that being really fluffy or wrinkly or hairless was a bad thing, but humans liked the way they looked, and we had time and money, and were starting to breed those type of animals. Now, many people that were involved in pet breeding didn't really know necessarily a lot about genetics. And even veterinarians and animal scientists in the early 1950s and 60s didn't know a ton about genetics. So sometimes they thought, if you really like the way an animal looks, how do you get more of it? Well, you should breed two that are related to each other, because if you like the way they look and they're closely related and you breed them, maybe you get double the good things. So there started a little bit of a policy or a principle, sometimes of breeding brother to sister animal or daughter to father, trying to emphasize the good genetic traits. But of course, that also emphasized the bad genetic traits that were diseases, which people didn't really know very much about. And sometimes these were small breeds that we didn't have a lot of in the country or even in the world, and so that locked in these inherited diseases in those breeds. So I, as we started this out, said I wanted to become a cardiologist, and that's what I eventually did. And the first one that really drove me to genetics was this one, Doberman Pinschers, because Doberman Pinschers suffer from a very fatal, very nasty form of heart disease. This was a dog I knew well, Zeus, who was about 5 years old, an amazing agility dog. So he would go in these competitions where you jumped over fences and ran and were timed, amazing, brilliant dog. And he came out of the agility ring one day and fell over dead, and he had this disease. And it was very, very common in Doberman Pinschers. And you can actually track this disease back to the development of Doberman Pinschers in this country. And the point is, this is one of those examples where in the early days, we embedded diseases into purebred animals that we are still dealing with today. When I get to the next part of my talk and talk about the future, we'll come back to this. But we built the breed of Doberman Pinschers in the United States out of a small group of dogs that came to the US on a boat after World War II. So American soldiers went to Germany and Holland during World War II and saw this breed, and they fell in love with them. And so they brought back 5 siblings on a boat. And then when they got to the US, they bred them to each other. And they were hugely popular. Americans hadn't seen very much of this dog, and it was big and smart and active. And people wanted these dogs. And within 10 years, 50% of the dogs in this country were direct descendants of those 5 siblings. And 3 of those dogs died of heart disease. So just this one family pretty much gave us the heart disease we're still seeing in 2025 in Doberman Pinschers. And we locked it in, not intentionally, but by closely breeding. So these are examples of how we really started out breeding for looks and inadvertently got some health problems that were locked in. And that leads me to the next step of genetics and veterinary medicine, is that in the 1960s and 70s, what I view as sort of the grandfathers, certainly of small animal genetics, Dr. Don Patterson and David Detweiler, who were at the University of Pennsylvania, started seeing these inherited defects. So they saw the infectious disease go away, they were in the clinic, and they were seeing purebred animals that seemed to come with families. And they started thinking, there might be something to this genetics, and maybe we should look a little bit more at it as veterinary scientists. But that was the early days, and there weren't things like Iacocca or large spaces to keep breeding animals and set up a colony. So Dr. Patterson was particularly interested in a dog breed named the Cajun. Anybody have a Cajun or a Cajun? They're kind of fluffy looking huskies, and they had a congenital heart defect that when they got really excited would turn them blue and then they would fall over. And so he thought, this really looks genetic and I would like to breed it, but it's the early days. So he took them home and he bred them in his house, and his wife and the kids put up with these Cajuns that had this heart defect. And after he passed away, his son would tell this story about how the male dog that had this defect would sometimes get out of the house and run around the neighborhood. And he always knew which dogs were related, because if he was out in the neighborhood a couple years later and there was kind of a mixed breed dog that turned blue and fell over, he knew that was related to one of Don's research dogs that got loose. So these two really started the push for thinking about inherited disease in animals and starting to study it. And that really was how I think we got today. They really started pushing it, trying to identify genetic mutations. University of Pennsylvania set up a big area to do that, was very successful looking at inherited diseases in dogs and cats. And now we look at the online Mendelian inheritance and animal database, and we can see that there are almost 400 known single gene diseases in dogs and less in cats, but how many have been identified as genetic mutations? So there's been a real interest in this. And if you do some quick Googling, you find that this has really been picked up by the private sector. There's a lot of interest in being able to test your pet for genetic mutations. You can do that at many universities, but for the public, there are some amazing companies that they can just go order these tests, and there is a great market for them now. As all of that came together, the discovery of genetic tests and then the rapid availability of these genetic tests for any breeder or veterinarian or just dog lover or cat lover, I think many of us in the field made two assumptions. I know I certainly did. And the first assumption was these genetic tests will put an end to inherited diseases. I'm not going to have to worry about Doberman-Pinscher heart disease anymore. It's an awful disease, but it's going away because I'm going to find a mutation and then we'll fix it. We also assumed that veterinarians would embrace it. I'm a veterinarian. I assumed that people would be doing genetic tests in clinics left and right, and that these would be incredibly powerful. I don't think it has gotten to that point, and we've made some missteps along the way, in my opinion, and we'll have a panel discussion in a few hours, and some of this is clearly just my opinion, so people may disagree, but I still believe there's a lot of power, and so I want to talk about some of the assumptions and how we can get back to going the right way. So I believed that once we identified the mutation, we could selectively breed away from it. In a few generations, it would be gone. This was an incorrect assumption, and I think it has turned out to be very false for a couple of reasons. We assumed that pet breeders, pet enthusiasts would embrace these tests, and I'm not blaming them, but they didn't. Some did, but some didn't. And I think that was a little unexpected. I think there was fear that as you do genetic testing, you might find that my favorite line has this disease, has this genetic mutation, and then I'll have to get rid of all of my cats and I'll be blackballed from the organization. Whereas others thought this is a great thing. Maybe they knew they didn't have a problem, I'm not sure, but it wasn't embraced. Some people liked it, but many didn't. And in the age of social media, those things spread around very quickly. The next thing that ended up being a problem is that many of these mutations have a very high frequency in the breed. So I went to Jim's lab to study this disease. This was the cat disease Terry asked him if I could work on. This is a disease called hypertrophic cardiomyopathy, where the heart muscle thickens inward, and then the cat's heart is so abnormal that they either die suddenly or they go into heart failure and have to be euthanized because they're drowning in blood that's backed up into their lungs. It's a difficult disease. We did eventually identify a causative mutation, but 35% of the cats that tested had the mutation. So that led to some confusion with breeders as well. How can this breed of cat have 35% that have the mutation, but yet they're not all sick and dying? And I think the problem is that early on, many of us, myself included, as we developed genetic tests and found these mutations, we lacked the understanding and certainly the communication to people about the complexities, that there's incredible variations in penetrance, expression, complexities of genetic diseases. We can say, yes, your animal has a mutation, but we can't say for sure your animal's going to develop disease. I believe that is still very powerful information, but unless you explain why that's powerful to people, they tended to think this is a bad test. It says my cat is positive or my dog is positive, but it never got sick. This must not be a good test. So we didn't explain that. There was also a great misunderstanding of what test results tell us. They identify risk of disease, not presence of disease. And then, and I'm not blaming anybody, the popular and ready available of testing meant that some testing services, I'll even say ours sometimes, said you get a discount the more tests you run. Not the more animals you run, but the more tests you run. So if I want to test my cat for heart disease and it's $15 a test, but I also test it for kidney disease and blindness and hair loss, then the tests are only $10 per test. So that seems cheaper. I'll do that, even though my breed of cat doesn't get kidney disease and blindness and those things. But then I get those results back, and some of them are positive. Well, what do I do with that? So a business model that encouraged people to test the wrong population, which gives us false positives, didn't help us. So the wide availability of these genetic tests, and now some of them, and this makes sense, again, no, these are all great companies. One of these tests, when you submit your dog's DNA, it tests for 270 different disease markers. That's amazing. You get 270 different pieces of information, but as an owner, if 30 of them are positive for diseases, what do you do with that? And so all of that information led to what were viewed by veterinarians and pet owners as false positives. Statisticians would tell us that confidence in a test result being true and valid depends on the combination of the test being good, and that's pretty easy. We can do PCR and say, yes, that base pair is abnormal, but also the disease frequency among the individuals tested at that point. So if we test a bunch of cats that never get kidney disease, and a few of them show up positive for this genetic mutation, those are probably false positives. We tested the wrong population. So we need to target the test to those that are at higher risk if we want to increase confidence. So this really lost confidence in the pet breeders. They made this assumption they were going to get rid of their disease, and it didn't work out for all of those reasons. Very briefly, similar things happened in veterinary medicine. We assumed clinicians would embrace these tests and move them into the clinic. And in the early 2000s, several companies actually went to the American Veterinary Medical Association and encouraged veterinarians using these tests to test every patient they had in their clinic. Every new cat or dog you have gets a genetic test with the idea that causative mutations would be identified and could be managed. And that also turned out to be a bad assumption. because we now know that these causative mutations tend to be very breed specific. When you put them in a mixed breed animal, often other genetic modifiers or other polygenic impacts dilute the effect of that disease mutation. Many animals have many disease-causing alleles but won't ever develop the mutation. Mutations are breed specific. And also, in this country, very few companion animals have pet insurance. That is increasing, but it's pretty low. So for most pet owners, every test they run is out of their pocket, and they have to think, is the value of this, is that going to help my pet? So running a $150 test that's going to tell me my dog is positive for 30 different mutations, but I don't know how that'll improve its life, is not maybe the best use of funds for some cases. So veterinarians have not largely embraced this as well. Now, I'm here, one, because I'm so thankful to Jim and Texas A&M, but I'm also here because I believe genetics is really the way to be proactive with medicine. We just have to use it the right way. But my profession has done some damage to the reputation of genetics, and so we're going to have to get it back, but there is power to it. And in my last few minutes, 10 minutes, I'm going to talk about 3 ways that I think it actually does make medicine proactive. So used properly, I think we can fulfill those earlier assumptions just in different ways. We have to use the tool properly, selecting the right populations, and we can use this information to develop better therapy, maybe even get rid of diseases. I think the 3 ways are individualizing patient care when we're running specific breed-specific tests for that patient, careful selection. I think we can use it to develop novel medications based on what those mutations are doing. And I think we can strategically breed to reduce the prevalence of it, probably not remove it. And so I'm going to give a few examples of those 3 things. Many owners who decide they want a pure breed animal have put a lot of thought into it, and that this is different. Many of us have mixed breeds as well. Genetics at this point in 2025 is probably best used for purebred animals where those mutations have been identified in a purebred animal. Individuals that buy those animals often have put a lot of money into it. They've often waited a long time to get that ragdoll kitten they want. And so for them, using genetics to know, does their pet have a mutation that is important for their breed? And if having that information allows their veterinarian to be proactive and think about lifestyle, or does it need to be started on a drug because it may eventually develop this disease, those type of things may be worth it to that individual that wanted the purebred animal. One of the diseases I study is a disease called boxer cardiomyopathy, or heart disease. This is a disease where the heart muscle almost starts to dissolve. I don't know if I can use the pointer, but so this one, the normal dog, that looks homogeneous, that's normal muscle. That side there is the disease muscle. The cells have pulled apart and been replaced by fat. This diagram is a hinge or a desmosome that holds the cardiac cells together. If that hinge or desmosome breaks away and the cells can no longer talk to each other, they start to die and they get replaced by fat. When that happens, that disrupts the electrical system of the heart. So we all have hopefully all have a good electrical system in our heart that is beating very normally, and you can see that on the, on the electrocardiogram. This is normal heartbeats. When I've got this fatty infiltration, then I get some normal heartbeats, very erratic heartbeats. The dog faints because its heartbeat is going so fast, or dies suddenly. So that boxer is out playing frisbee with the family, falls down, and is dead. Very sad. We discovered a mutation in a gene called striatin that is a large deletion mutation, and it turns out that that mutation is right there in that hinge, that protein, is right there in that hinge. When that protein is abnormal, it doesn't allow the hinge to hold the cells properly, especially when the dog is exercising. Those cells pull apart, die, fill with fat, develop that cardiac arrhythmia. So for these dogs, if I have a client who wanted a boxer puppy and they went out and spent $2,000 because they really, really wanted a boxer puppy, I can test that boxer puppy for this mutation. If it comes back positive and it is homozygous, that dog has a high likelihood of eventually developing this disease because it is a higher level of penetrance just for this disease, not for all diseases, but if it's homozygous. So by testing, if it comes back positive and if it is homozygous, the veterinarian can develop an individualized treatment plan to proactively manage this case. If you start this dog on antiarrhythmics, it will never, not never, but it will have the same lifespan as a dog without this disease. So its chance of dying from this disease significantly reduced. So this is a place where the power of genetics allowed you to make a proactive plan for this dog to not be impacted by its inherited disease. Also, if the owner really wants to breed it, I can help them. If it's homozygous, should definitely breed to a negative so I don't have more homozygous, etc. Number 2, development of novel therapies. If you know exactly what that mutation is and what it does, then you can really think physiologically and pharmacologically how to best treat it. This is the cat disease that I went to gym with. This is hypertrophic cardiomyopathy. Normal heart here. Here's the abnormal one. The heart muscle thickens inward, making this area very small. Cat dies of sudden death, or it drowns in fluid going backward into its lungs. And this is a Maine Coon cat, the first breed that we really looked at. This disease is also very common in people. In both cats and humans, it has a prevalence of 1 in 500. This is Hank Gathers. Some of us that are old enough may remember Hank Gathers. Anybody in the room remember Hank Gathers? Thank you. So Hank was an amazing basketball player, college basketball. Where's Mike? So Hank played for Loyola. And in March Madness in the, I think it was late 80s, as he was warming up for a big game, he fell over on the basketball court and died of hypertrophic cardiomyopathy. Disease very similar in cats and actually same genetics. We discovered a genetic mutation in a gene called the myosin binding protein C gene. But what's important is that this gene, as well as the ones that Hank suffered from, they all are in what's called the cardiac sarcomere. Your heart contracts, and it contracts because you have a number of proteins in a sarcomere that engage with each other and then pull apart to relax. So these proteins swing up, grab this, release, and they keep repeating it, and that contracts your heart. If you have a genetic mutation in one of the genes that encodes those proteins, this tends to get hyperactive, forms too much tension, and the heart gets thick. So if you mess up this, you get that. And that, if you're a human, you might get a transplant. If you're a cat, you're going to die of this disease. So now, understanding that, pharmacologists are able to say, great, what can we do to look at ways to impact that sarcomeric area and prevent that hyperactivity of the mutated proteins? We're not going to change that person or that cat from having the mutation, but we can influence the impact of what that mutation does. And so there was a company that came up with a new drug called mavacamten, and this is Dr. Josh Stern, who was one of my graduate students. So I view him as a descendant of Jim Womack's. Now a faculty member, was at Davis and is now back with us. And he was able to look at this drug in cats, and they've also looked at it now in people, and demonstrate that if you use this drug to modulate that protein that has the mutation, less of the proteins are engaged. So here's the proteins that they reach up and engage with, and once you've given mavacamten, less of them do. So development of novel therapies, once you identify the genetic mutation, can be very helpful. And last but not least, number 3, we can use strategic knowledge of these genetic mutations to breed away from diseases. I think it's highly unlikely we're going to remove very many of them, which was my initial dream, and that's okay. I'm all right having broken dreams. But what we can do is reduce it. So we can think about, can we make genetic strategies to reduce, not necessarily eliminate these? So I started this wanting to stress that I think medical professions have historically been largely reactive. The infectious disease people have probably done the best job of moving towards proactive. I believe that we can, as geneticists, do the same thing. Here is our opportunity to allow us to move to this proactive aspect. We do have to use these properly, and we've started off in a little bit of muddy waters, and I think many people have lost confidence in them. But there is real power to these, and we want to get that back. And so I think there is a lot of ability to turn the way we look at inherited disease and managing these cases around, but it's going to take a little bit of time, and it's going to take strategically using these tests in the correct way. And with that, I almost could cry. I have to say thank you to Jim. It's been a heck of a ride. I've loved genomics and loved the power and the good days and bad days. I ran so many SSCPs in his lab. I could probably still glow from that radiation. And had he not said yes that day when we came to his office, I don't know where I would be or what I'd be doing, but I wouldn't be having as much fun. And I can't believe he did say yes, and I can't believe I had the opportunity to work with so many amazing people in this room and to be part of Texas A&M and have this degree. So thank you very, very much.
Time for questions. I'm going to jump on the first one then. So, Kate, that was wonderful. Thank you. I think when the human genome and all came out, and Francis Collins says pharmacogenomics is going to be here tomorrow, and do you think there's an opportunity with companion animals and spontaneous diseases and some pet owners that have the means and love to do everything they can, that there's an opportunity for companion animals actually to win the trust of the public? I love what you said about us immunologists, but we failed in some of the communication aspects in the last few years, right?
I do think pharmacogenomics, that there's so much there, and that we just haven't worked on. There have been a few successful things. Katrina Maley, who started here many years ago in Steve Safe's lab, I think, has been very successful with the MDR1 mutation. But I think that is the tip of the iceberg. There's a lot there, and I think that would be my dream, that if before you give a drug, they're doing that a little bit with chemotherapy, that you're testing for those things. We just need more people to study it, I think, is actually part of it, is getting people that are interested in veterinary medicine and these diseases and companies to have more graduate students that look at pharmacogenomics. Some we can adapt from people, but it's just different enough that it often doesn't work. It's a great question. Thank you.
Thanks, Kate. Beautiful talk as always. And you know we share a passion for this area. Where do you see polygenic risk scores in veterinary medicine, right? This is something that I think we've talked about before.
Yeah.
But what do you think?
I think that as veterinary genetics, we've done a pretty good job with the single gene. I think I have a lot of particularly birth defects, congenital heart defects, valvular disease, hip dysplasia, for people that don't like cardiology, probably are these complex polygenic. And often I think having the sheer numbers sometimes has reduced the power, and that'll be a great one for the panel discussion. I'm always hoping somebody's developing a new computer program that's going to help find ways to analyze that data with lesser animals. But I'm waiting for somebody to have that breakthrough. It's a really good question.
Very nice talk. Thank you. Could you comment on the role of a breed registry versus the breeder or pet owner in implementing these rules you're suggesting?
Yes, it's really, it has varied tremendously from dog and cat and even within species. Sometimes the breed organizations have come out very firmly, and sometimes I think have gone overboard. You can't breed anything that has this mutation, and they've done that for 5 years, and now instead they've gone from having seizures. There was a situation with Irish setters that had epilepsy. It was a blindness mutation, and they were very, very strict. And then you could not breed any dog that had that mutation. And then 5 years later, they had a big problem with epilepsy because they'd kind of shifted families. And so they'd removed all of those dogs because often the gene pool is pretty small. So we've sometimes had breed organizations that have been very firm. Sometimes it's the pet owner. Sometimes the breed organization has been very rational. Sometimes it's the pet breeder. So it's all over the place. And I don't believe it's one better than the other. And they're all well-meaning, but genetics is so complicated, and they often don't have a ton of knowledge, and so they're just trying their best. But I don't think there's any hard rule of thumb which believes it more than others.
Hi. I was just wondering if you think that some of these mutations have an additive effect, and that's why they're being selected for. You're nodding your head. I'm thinking like on the Dobermans, because they're agile, athletic, the heterozygote might have desirable traits.
Absolutely. And we do know some breeds, and that will probably come up in the panel, where it's linked to that mutation is really fixed in the breed and often linked to something that breed really likes. And I think that was with Dalmatians and the spotting pattern. And so they had a bladder stone issue that was linked to the Dalmatian spotting pattern, and which way were they going to choose? And so it's very, very hard to help them work away from those, and it takes years. These diseases I just talked about, 10 years later, they have reduced the frequency of some of these mutations in the breed, but it takes years to do that. So I think that's absolutely right, and just another area we don't understand very well yet.
Other questions?
Thank you.